start. Good afternoon, everyone. I'm Aurélie Martin from the French Chamber of Commerce, and today I'm very pleased to welcome our speaker, Laurent Rignard, for our casual French Lab meeting, AfterLab COVID-19, today, prepare tomorrow. So French Lab Singapore is a joint initiative by CNRS, Ambassade de France, and French Chamber of Commerce. Please note that this presentation is recorded. And before we start, I would like to remind you few rules because it's a Zoom meeting. So if you have any question, please feel free to ask your question during the presentation in the chat box, and our speaker will have a look. After the presentation, if you want to have a question directly to our speaker, please raise your hand and we will unmute your mic and put your camera on. So thank you all and enjoy the presentation. I'll pass over to you, Laurent. Thank you.
Thank you, Aurélie. It's my great pleasure to present to you today what we have done on COVID and what in Singapore we are going to plan to do. So my chat box, as Aurélie mentioned, is open. And if you have questions, please don't hesitate, type it. If you don't understand or if I go too fast, just mention it. So I will start now. If my computer wants to move. Okay, it does. So we have been now for nearly 1.5 years in the COVID-19 pandemic, and you could see that it had changed the world a lot. It had changed our life, changed our economies, our ways of interacting with others, with the mask, the social distancing, our practices, and for many, they are common senses for people, for scientists, for doctors. And he has revealed the weakness of various health systems and also in our scientific education, where people go and grab in YouTube some piece of information and sometimes cannot make sense of it. And it doesn't help when you want to understand diseases. So what is the situation right now? So if you look from the start in December 2020 up to now, we have around 1.8 million cases with billion cases. I made a mistake here, and 3.8 million deaths, which is a major pandemics. And you could see that it's well distributed with less cases in Africa, but this might relate to the fact that testing is not as widely used as in other countries. Okay, come on. Okay. So what is the situation in Singapore? Up to March last year, we had few imported cases and the situation was under control. However, from the April 7th, we started to have a major peak of cases, and this happened in I would say, the weak spot of Singapore, the Dome, where you have a high concentration of people, and then the virus really spread to this population and reaching up to 100 to 1,000 cases per day. And at the peak, which was nearly 2 weeks after the first cases in the Dome, it reached nearly 60,000 cases. So we went down after the government imposed what we call now the circuit breaker, which was Singaporean way of saying lockdown, and then the situation went under control. But okay, I'm sorry, maybe I put too much pictures. Okay, doesn't want to move. That's a case of circuit breaker with my computer. So here was a circuit breaker. You could see for those who are really used to Singapore before, where it was crowded everywhere, and especially in the back in Changi, you could see the decrease in people coming to the airport. It was a major stop of all the social activities and economic activity in Singapore. So what is the situation now? So the situation is stable since June last year with a small increase of cases, but not major. But recently we had a new peak of cases, and not a major one, maximum 30 cases in the community. But the government is afraid of this disseminating in the community, so they impose another circuit breaker, and this allowed to bring down the cases where we are now, and they are going to be reopening soon, but to very slowly. So why, you could ask, what the situation was under control, why did we have new clusters? There are now new cases due to the Delta variant, and I will explain to you later in the presentation what are these Delta variant. Singapore, it's an open country. The border cannot be completely closed, so you always will have imported cases. And that's exactly what happened, because most of the cases were from imported cases, and mainly for some of the clusters, they originated in Changi Airport, where some of the staff who are in contact with the travelers went into food court and started these clusters. And despite that, today, close to 40% of the population is vaccinated. And I like this representation where you could see this little round there when you have one case and how it could spread into the population, one case being distributed to the different contact. So that's why contact tracing with the app is important, because you could locate which people have been in contact with the original case. So if you look back in history, in 2003, Singapore was hit by SARS. But because this disease was very transmissible during the first cases, where people became very fast symptomatic, so you didn't have asymptomatic case. So if you identify this symptomatic case, and you isolated the people, you could contain very fast the spread. And that was what was done. The people who were infected and died from the SARS epidemic were mainly healthcare workers. And when they were contained in quarantine, which were already in place at that time, the disease went off. In 2019, SARS-CoV-2 came, and beside the enormous human cost, you could see that he has a huge economic cost. SARS cost 1.2 Singapore billion dollars in around a period of 3 to 6 months, but COVID-19 only for 2020 cost more than 25 billion Singapore dollars. So you could see that infectious diseases, infectious death rates could really have a huge impact beyond the human health. So, but from 2003, when SARS-CoV-2 approached, the government was aware that new diseases could come back. But so that was the idea of clinicians in Singapore to be prepared and set what we call the Protect Project, and to be ready with also the building of the National Center for Infectious Diseases, to be ready if a new emerging infectious disease was coming. So this was the brainchild of Prof. Leo Yissin and Prof. David Lai, together with Prof. Barnaby Young, which are clinicians in the National Center for Infectious Disease, and with multiple partners from the different universities, from A-STAR, we were ready to react, because we have been working together for more than 15 years. So we got the indication the 29th of December of a new respiratory illness in Wuhan. We activate the Protect project that we have been working on for at least 2 years. And we brought together a consortium of infectious disease clinicians and researchers. And we started to have regular meetings. At the beginning, it was weekly meetings. And that was necessary to set all the ethics and the safety approvals and all the legal documentation that are required when you work with humans. And also to define what type of samples will be collected. At that time, we didn't know if it was better to collect blood, to collect saliva, and so on. So we had to go and be prepared for all this type of collection, timing of collection, when the people go to the hospital, how long you follow them, and so on. And now Also, how do you manipulate this sample? So you need standard operating procedures that can be shared with different partners, and everybody does the same. So you could compare your results. And also, how would you distribute? This was a new virus. We didn't know if it was very easy to disseminate and so on. So we needed to have safety, security, safety operating procedures in place. And because of that, how you distribute samples between different partners to respect these safety imperatives. And so, because it was a new disease, even if it was the same family of coronaviruses, we had a lot of questions to answer at the beginning. Do we have a good diagnostics? Can we isolate the virus? What are the methods to extract the nucleic acid, the genetic material of the virus for diagnostics? Do we have serological assays? Can we develop serological assays? What is the impact on the community, and other epidemiological questions? So in the first days of the pandemics, we were confronted with a lot of questions. We knew barely nothing about for this virus. What is biology? What is etiology? What type of disease? What type of symptoms? What the organs are attacked by the virus? How does it spread in the community? What modes? Is it in the air, aerosol, by touch, and so on? All these were unknown. Can we have good method of detection? Faster laboratory method, and then method that you could transform into point of care test, like the pregnancy, the equivalent will be the pregnancy test, something specific, sensitive, and very cheap. And then can you develop treatment or reuse drugs that have been used for other things and test against this virus for repurposing? And then at last, can you prevent it? And one way to prevent any infectious diseases is going vaccines. And so can we develop vaccines? How do we evaluate these vaccines, and so on? Come on. Okay. Sorry. Okay, so just a recap for those who are not familiar for how SARS-CoV-2 infect a human is usually through the air. There is still discussion if it's aerosolized or not, and small particule, you will enter through your nose or your mouth, go into your lung, and then you will have symptoms like cough, shortness of breath, sore throat. It could also disseminate from the lungs to other organs, so you could have nausea, loss of smell, loss of taste, but also other symptoms like fever, fatigue, headache, myalgia, and even confusion. And so you could diagnose many ways. The gold standard here is RT-PCR, and I will explain to you later how we do that. You could also test for antibody. When your body is attacked by a pathogen, it makes this antibody. So you could look at the specific antibody to see if you have been in contact with the virus. There are blood tests who also can indicate that you have been in contact with the virus, but they are not very specific. And also to look at the pathology using X-rays, because the first site of pathology is in the lung for this virus. So in SIGN and in the ID labs, where I worked and had a group, we are always been interested in looking at the immune response of the body. So we receive samples from the clinic. We do an extensive characterization of the immune response. And for that, we look for biomarkers, which are a type of molecules of cells which are specifically increase or decrease in response to the infection. And that could give you ideas how to develop treatment if you understand the mechanism by which this increase or decrease have been induced. And then you could design a new intervention using drugs that have been used before, so it's called repurposing, or develop another intervention like monoclonal antibodies that you fabricate in the lab and that you could re-inject into the patient for treatment. Come on. Sorry, I think I have too many pictures, so he doesn't like it. Here we are. So together with my colleague, Prof. Ung, we first looked at these mediators that could be induced by the infection. Okay, come on. I'm sorry, it really doesn't want to move. Okay, so if you look at this complex graph, but I try to make it simple, the dotted line is the level of these mediators that are in normal, non-infected people. And you could see here, we followed 81 patients, that some of these molecules are increased compared to the dotted line, which is the healthy patient. So to make a story short, what did that tell us? It tells us that these mediators are characteristic of a strong inflammation, which has been reported by many other researchers. And so if you stratify or do an analysis depending on the severity of the infection, here on the left you have the healthy controls, and you compare the people who are no pneumonia, we will call them mild infected, those who pneumonia without hypoxia, moderate, and those with hypoxia, the people who are in the ICU and intubated. You could see that just looking at these mediators, you could visually see that there are differences in the patients. So you will say, okay, it's very nice, but what does it tell you? First, it tells you that indeed there is more inflammation in the people who develop severe disease. And second, as an application, you could you may want to control this inflammation. And one drug which has been shown to be very efficient is the corticosteroid, like dexamethasone, which was shown to reduce mortality in many trials in the world. So having a knowledge of this could really indicate what type of treatment you could apply. Okay. And though now we are continuing, because the data that I show you was during the acute phase, which occur between 7 to 20 days after the infection. And now we are following the same patient. We have a cohort of around 100 people, and you see that up to 150 days post symptom onset, a lot of these patients still have a very inflammatory response. Again, the dotted line represents the LC controls, and you could see, for example, for this marker, BNDF or MIP1 beta, the levels are not going down. So this clearly tells us that in some patients, they have not recuperated for the infection, and that characterizes what is called now the long COVID patient. So this also indicates that we may have to treat this patient against this chronic inflammation to come back to the basal level and really fully recovered from the infection. So another part of the lab was really, can we develop a sensitive assay when the people are infected, and when we could go faster than the PCR. The PCR it was taking 2-3 days before having the results. So can we have a fast screening which helped triage the patient? So we developed in the lab a technique that we call the S-flow, where, to make a story short, we introduce into the cell the S protein of the virus, and when the cells is expressed on the surface of the cells, you could now use the serum of the patient. This antibody will react to the cells, and if you come with an antibody which recognizes this antibody, you could stain these cells. So for those who are not familiar, what we are interested in and what we should look at is this quadrant here. Here, when you have no antibody from the patient, you see that there is nothing in this quadrant. And when there is antibody, you see that there is a response here, telling us that the patient have antibody against this the S protein. And the advantage of that is now we could follow the response of the patient, and I will show you here. If you look at the type of antibody that are produced, in the human, IgM are the first antibody to be produced, and then you have the immunoglobulin A or the immunoglobulin G, IgA, IgG. And so we could test specifically these immunoglobulin, these antibodies, and you could see that in green, 5 days after infection, after the beginning of the symptoms, some people already develop antibody against the virus, but you could also see that some people don't develop antibodies. So it's not as accurate as a PCR, because we tested all these people and they were all PCR positive. When now we look at the IgA or the IgG, it was the same when we look at the early response, but now you could see that when you look at the later response in blue, now specifically the IgA more than the specifically the IgG, when you compare to the IgA or the IgM, are all positive, which means now we could detect all people who have been previously infected 23 days before. And to see what was really the impact of this technique, we compare with the two assays. One's called CPAS, which also measure some antibody against one region of the S protein, but also another commercial assay called RDT. And you see that our assay, the SFB, recognized very well the positive in all the case. And we have different groups here. We have people who were PCR positive, that people who were at the hospital with symptoms, with no symptoms or non-symptoms, and we were always able to pick them. And we also looked at the population where we didn't know if these people were PCR positive or if they have symptoms, and we could pick people who have been exposed in the population without developing any symptoms. So this assay is used by the National Public Health Laboratory when they have borderline cases or unknown cases to verify if these people have been exposed with the virus. So now, as I mentioned before, I'm going to talk to you about the virus, the variant virus, which is responsible for the later outbreak. And if you have been looking at the news recently, the major outbreak that we have recently were due to a new variant, which now is called Delta variant. And 50% of the cases are due by this variant. For Tom, again, with some of you who are not familiar with what the virus looks like and what we are looking at, the virus is called coronavirus because the structure is like a crown. And on the surface of the crown, you have this in green here, this spike protein of the S protein, where you see the structure here is made of 3 monomers, and this forms these 3 compact trimers. Inside this virus, you have here the string of RNA, which is the genetic material that which is depicted here, which encodes for many of the protein which are necessary for the virus to enter the cells, to multiply, and to exit the cells. And when we do a detection by PCR, we use probes here, which will amplify specifically this part of the molecule. We cannot amplify the whole virus, but we amplify this molecule. So this PCR, in fact, is a huge multiplier. So if you have few strands of the virus, you could end up with millions, and that's what you visualize. So now when you look at the virus and how this virus evolved during the infection, so the L here was the original strain which happened in Wuhan. And all the little lines that you see is how the virus over time has mutated. And now there is more than 1.5 million sequences of the genome of the viruses. And you see that it has really varied a lot. So what does it mean? It means that some variants will be completely useless and the virus will die because it is not able to enter in a cell or to multiply. But other variants could be better at entering the cells, are growing inside the cells, or are being passed from one person to another. And this will vary over time because population build immunity. There is also the the separation, so how do you facilitate contact or not. And if you look from December 2020 to June 2021, and we only have a small sample of a sequence because they keep coming, you could see that at the beginning we have the L, which has completely disappeared, the virus from Wuhan. And here in the yellow one, the yellowish one, which is called alpha, where this virus until March was in the UK and spread all over the world, and now is replaced progressively by the Delta and the Eta variant. But the Delta is the one which is growing and is the one responsible for the later outbreak in Singapore. So what do we care? We care because these different variants, as I said, different capacity. Some could transmit better, like the UK variant, very good at transmitting from one person to another. Some are very good at escaping the antibody response. Your antibodies will not recognize, the cells which kill the infected cells will not recognize, and so this virus could escape the detection by the human host. And so we did recently a study in the lab where we compare all the variants. Here are all the mutation in the genome in the S protein. So every little colored box means that the virus have changed an amino acid, one of these components. And when we test antibodies from people who have been vaccinated, and we look at the capacities of this antibody to block the virus to enter our cells, you could see that antibodies block the original strains because the vaccine is meant against the original strain. It neutralizes to a certain extent the other variants. So the one from, for example, from UK, this one from South Africa, this one from Brazil, and this one from India also, or this one from California, but is less efficient against the Delta variant, the Indian one. So which really tells us that and confirm that this virus was able to escape the immune response in people who have recovered from infection or people who have been vaccinated. And the experiments I showed you were done in the laboratory, in plates, in tubes, but does it really matter when you look at the efficacy of the vaccine in different regions? It does matter. If you look at the different vaccine which has been implemented in different parts of the world, Pfizer, the one we have in Singapore, for example, when we look at the efficacy against symptoms in Qatar, when they look at the efficacy against the original virus, the Wuhan virus, the efficacy was very high, 90%. But now they realize that the efficacy was decreased against the variant from the UK. The most really striking was the vaccine from AstraZeneca, which was deployed in the UK. When it was tested and there were the strains, the original strains, the vaccine was very efficacious, 84% protection against symptoms. But in now South Africa, where most the case where again these South African strains, the vaccine was not efficient. So you could say, depending on the virus, this is not very good news. It's still good news in a way that, except from the AstraZeneca, the 3 other vaccine reduced to 50%, which is still not bad. It's not the best, but it's still not bad. But what is good is that despite that, it protects against severe disease. It protects against you going to the ICU. So you get still sick, you could still transmit, but you don't end up in the hospital. I just want to make the point that 73 to 80% doesn't mean 100% like you see here. It means that some people, despite being vaccinated, could still develop severe disease. So it doesn't, even if you are vaccinated, you still have to wear a mask. I know it's very painful for a lot of people. If you are in a place where there is transmission, if there is no transmission, you could remove your mask, but where there is transmission, you could have your mask and respect social distancing. So in conclusion, for that part, the virus is always evolving. The variants arrive frequently. This could impact transmission, could impact disease, could impact the immunity that you have acquired when you were infected, impact the immunity that you acquired by vaccination. I didn't have the time to go into details, but it could also have an impact on the diagnostics. So you have some variants, we have to change the diagnostic PCR to make sure that you could see these variants. And so there is a need to monitor the emergence of new variants. You need to sequence, you need to always monitor the efficacy of your vaccine. And what does it matter? Because maybe in the future, if the variants are so efficient that they escape all immunity, you may need to have recall injections or develop specific vaccine against variants or develop what is called prime book strategy, one mRNA vaccine followed by another type of vaccine. So this monitoring will be important for the future of the vaccination strategy. So now, what did we learn from the COVID-19 during these years, and how we prepare for future infectious disease threats and epidemics? If you look at the global burden of emerging and re-emerging disease, you could see that we don't live in a world free of disease. People tend to forget because most of the time there are cures for that. If you are infected with bacteria, you take antibiotics. But in many places, you could be infected by tons of viruses, of bacteria, of parasites. And you could see that even in developed countries like in the US, it doesn't prevent you to be infected with emerging disease. It could be virus you never heard of, like Powassan virus, even fungi like Candida, measles. Even if we had a good vaccine against measles, because people are against measles vaccine, there are more and more cases, and so on. And I show you these slides represent what we have in 2017. And in 2017, we didn't see, we knew that we had other coronaviruses like MERS, but we didn't see SARS-CoV-2 coming. So that's why we need monitoring. And there are many studies, and one here show you that where the novel infectious disease could most likely emerge. And you see that even if it's mainly in the tropical region, in the southeast hemisphere, it could still occur in a temperate region and in Europe. So nobody is really immune or safe for new emerging disease. And it's usually due to zoonosis, or in French, epizooty. Thanks, Naomi, for the word. What does it mean? It means that a lot of animals carry viruses, carry bacteria, and carry parasites. And these viruses or bacteria that they carry could be transmitted to human. And so if you look here at the list of these viruses, they were all coming from animals. The Hong Kong flu comes from pigs, the MERS come from camel, the Ebola come from bats, which went into chimpanzee and gorilla, and the Zika virus or the chikungunya virus came from monkey before going into human. So these are viruses, pathogens, which could transmit from animals to human. And this will be even easier if we get into contact with these animals. So one of the places is the animal markets, where you put together animals where in nature they will never be together, like for SARS, civet and bats were close together. Like wildlife, people go and hunt animals in the wild and use it for food or others. Intensive farming of other animals, and even domestic animals. I mean, pigs, for example, could carry the flu virus, and chicken salmonella. And here you have a study which was done a few years ago, looking at the relative influence of different activities on the possibility of emergence of new pathogens into human population. And you could see it could be divided into three activities: human activities, animals that you come into contact, but also environment. And what I mean by environment, for example, Deforestation. Deforestation is one of the major change of the environment. And if you deforest, you bring animals which were deep in the forest in contact into domestic animals or into humans, and then you favorize the transmission into human population. So this is a dark situation that I showed you, but if we are serious, we can fight back. Here is a scheme which showed you that what was the situation, for example, in the US in the 1900 to now. And you could see on the scale here that you have nearly 800 deaths for 100,000 people per year due to infectious disease in the US. And then in the 1920s, they created public health department to monitor the water, to monitor the number of disease due to infectious disease. Then you see something as simple like using chlorine in the water decreases the number of deaths, mainly decreasing the number of bacteria that you have in water and drinking water. And you see peak of flu, deaths increase again. And then control of plague, and then you add a progressive decrease. Then in the 40s, beginning of the antibiotics, and you see it really increase the decrease of infectious disease in the US. And the really first vaccine to fight polio by the Sol vaccine, and then we came to this very low level and vaccination against many diseases that you know, and now we're still at this low level, and this is mainly due to the bacteria that are emerging, the new viruses. But you could see that because of science, monitoring, public health measure, there were a massive reduction, and it happened in all the developed countries. In many developing countries, this has not been possible because this costs money. So for Singapore, what it's important to monitor. Singapore is a high population density, one of the highest population density in the world. So that favorizes the spread of the disease. It was before the lockdown, a global transportation hub. And you could see that you have flights going everywhere, and you have a port where there were maximum exchanges between the West and the East. And despite that, you could see that since, and I only started in 2003, we had a string of diseases in Singapore, emerging diseases: flu, chick, malaria, Ebola, Zika, no case of Ebola, but Zika, and even a case of monkeypox that we, even in Africa, he thought it was extinct, and emerging mycobacteria, and in 2020, SARS-CoV-2. So we know it will happen again. So what we are planning for the future, there is a program at the Singapore level called Prepare, and there will be an increase of surveillance and detection capability, looking at diseases which are endemic like dengue, antimicrobial resistance due to resistant bacteria to antibiotics. How can we develop new drugs and vaccines, and also diagnostics? I will not go into the details of all the activities that will be developed in the ID labs, in the Efficacy medicine, and other part of the university and the hospital in Singapore. And this will be managed at the national level, and that will also be integrated with the regions through networks with other Ministry of Health and other university, to make sure that we are ready when there will be a signal for a new infectious disease threat, and that we could develop rapidly new tests, new drugs, and so on. And I will stop there. This is work of many people from my group, from Lisa's own group, from people from SIGN, the people from NCID, the clinicians, but also the recruitment of patients from all the major hospitals working on infectious disease in Singapore. And I thank you for your attention, and I will start to take the questions here. Okay, I'll start with Moderna vaccine efficacy on variants. No, okay, it was not on the chart because I have the data from Moderna only came last week, and I didn't have the time to update, but they seem to be, as the other, like the Pfizer, around 70 to 90% against symptomatic disease. Do you see a trend, Jean-Paul, to a more aggressive and resistant variant? That's a good and interesting question. For the moment, we see a trend of more resistant variant, but in the future, I cannot predict if we will see this trend, because the virus has start with one genome, and there is a number of mutations that it can have. It cannot have thousands of mutations, and the mutation will be indefinite. So there will be a fixed number of mutations. So many of these mutations will die off, and some of these resistant mutations will be selected. The thing is that over time we will also build immunity against this mutation in the population, and with vaccine we will also build resistance. So what could happen is that there will be recurrent waves of the virus in the population, which will go into the non-immune population. And it will be like the other coronavirus. It will be an endemic virus infecting people who are not protected. Which means the first part, I didn't go into the first part of which vaccine are more effective and less side effects. So far, the less side effects is Moderna compared to Pfizer. They are the top two for the moment. Sinovac are a bit also less side effects, but is less efficient. So like for any vaccine, which is like for any drugs, is a combination of benefits and risk. So you could have a very good vaccine, but if it has too much risk, you have to balance. And I always take the case of, if you are in a population where mortality due to a virus or any pathogens is 50% and your side effects is 10%, you will go for this vaccine. But if you are in a situation where the mortality is 1 or 2%, and then the side effects is 1% or more, then you have to reconsider. So it's really, you always have to balance benefits and risk. How efficient are the do-it-yourself kit? They are efficient if you are in a very symptomatic case, meaning that you could detect high level of the virus. When you are borderline, they may lose the sensitivity when you compare to the PCR. Okay, Alex, I read that France will focus more on identifying mutations and variants. Mutations and variants are going together. The thing is, we cannot anticipate what are the mutations. And even if we know the mutations, we don't know if these mutations are going to lead to a more difficult variant or less lethal variant. So we need to track both. Okay, Sylvia, patient data for biomarkers. Yes, the patient data was only collected locally. Yes, it's a bias, but yes, I know it's a bias, and we were interested in our Asian population at the beginning. There are other studies being done in the US which are looking at the Caucasian population, and there will be, and there are groups already starting that, doing what it's called a metadata, where you bring together all the data and you try to define what is specific from one particular region, or can you look at the can you find markers which are true for all population? But you have to start from somewhere. Benefits risk ratio for vaccinating teenager. That's something which is being discussed yet. I cannot tell you the position of Singapore. I can only speak for myself. I think for the moment, I found it a bit premature to go below 16 years old, because the level of symptoms or symptomatic cases in these kids is very low. So I would have waited a bit before going into vaccinating teenager. But again, this is, and I really stress to it, this is my opinion. New variants emerging. Can you let me answer? You go very fast. Is there a path toward herd immunity, total eradication? Okay, the dream of total eradication, you will never happen. I think we are in for a really endemic virus, and there will be places in the world where you will have not enough vaccine coverage, so you will have always reservoir of viruses which could develop and go and redisseminate in the world. So you could have a bit of herd immunity lasting for 2 to 3 years, maybe 5 years, but then you will have peaks again. So Moderna is the first choice of efficacy and less side effects. If you ask me for the moment, I will say yes, but again, it's my opinion, so take it as it is. Are pharmaceutical groups developing vaccine for big variants? Yes, there are. All the companies that you have seen developing vaccines are doing new platforms to develop the variant. And they even have started to test these new formulations in a population, in volunteers. Based on past pandemic, would it be possible to have a new wave of past variant? We could have single variants could come back in the future. There are other diseases where I'm just going to give you this example where I'm very familiar with. We use chloroquine. I'm talking about malaria here. We use chloroquine for malaria for more than 40 years. And then the parasite started to develop resistance. And so in Africa, they stopped using it for the 10-15 years and they shifted under WHO recommendation to other drugs and so on. And then we realized that after 10 years, the parasite which were resistant disappear, and we saw the parasite which were sensitive to chloroquine reappear. So if you don't put pressure on the pathogen, it will re-evolve normally, and you will have the re-emergence of the old variants. Okay, Bertrand. Children's, given the lack of visibility, again, my opinion, and take it as it is, I will take, if I recommend a vaccine, I always say that I will recommend a protein-based vaccine because it's the type of vaccine we have a lot of experience, and we know with the formulation that is the safest vaccine so far. So that, again, take it as it is, it's my opinion. Yeah, I will have people who disagree with me. Comparing global and Singapore cases, do you think the reason of low mortality rate here? Low mortality, simple, very fast detection. So you will not realize, but the government went to 5,000 PCR tests to nearly 40,000 tests a day in less than 2 weeks. And so all the dorms were tested. What was the first reason? Second reason was separation. All the dorms people were spread out, isolated when they were positive, and massive monitoring of all the dorms. And I can tell you there is still massive monitoring. We are around now 60,000 PCR tests per day in Singapore. And then the system was ready, so for ICU and so on, it was organized, so the severe cases were tested. And they already look at dissemination, what was the reason for dissemination. So that's where at the beginning, it was not clear if the mask was necessary. They did an experiment to show that if you don't wear the mask, you will there is probability of more aerosols, so that's why they imposed the mask, but it was based on science. It was not something coming from the air. So I think it was the public health system in Singapore was very strong. And I know it's a contentious issue, but the app was very important. At the beginning, they were doing it by telephone, tracking people, because if you contain and you isolate the people who are infected, you could contain dissemination. Okay. If someone critical ill after with COVID and still have antibody, does she need a vaccine? It depends what level of vaccine of antibody they have and what their antibody recognize, because we realized that the people who had the highest antibody level after infection was the people who have the more severe disease. And for the moment, after we did the follow-up up to 9 months, these people are still have high level of antibody, but this level are starting to decrease. So one injection of the vaccine, one is enough to reboost the antibody level. So again, my opinion will be that you get one shot. No need for these people who have been infected to get 2 shots, but 1 shot to have your level of antibody to a very good and protective level. Okay, what about temperature, humidity on the virus? I don't know, because there is no, we know a lot of transmission, a lot of viruses are seasonal, which means that the cases are more linked with seasonality, but nobody really is able to explain seasonality. So there are many hypotheses for that. One is when it's cold, you stay more at home and you facilitate contact in a closed environment. But I don't have really explanation, because, you know, before I came to Singapore, when I was in Europe, I always heard that the flu was seasonal. It was mainly during the winter season in Europe. But when I came to Singapore, I learned that, in fact, what we have tropical flu here. It happens every year, every time during the year. So the seasonality doesn't really matter for the viruses. Wow.
I had a question. So I had a question about long COVID, and I know it's something that's talked about a lot in Europe, but and you covered it a little bit in your slides, but I'm wondering, is it a problem in Singapore, long COVID? Are we worried about it, or is it not prevalent?
No, we in Singapore, the little core that I showed you, we don't have the same category that is found in Europe, for example. If you follow, there is a nice cohort in Sweden where the majority are women under 40. Most of the cases that we have here were mostly older people. So they may be, again, ethnic differences for the long COVID. But what I showed you in the little cohort that we have is that even after 6 months, you're still not back to normal. So you may feel okay, but this may influence that you may be a bit more tired, you maybe have a short of breath and so on, but you're not sick, but you're not back to completely healthy. So we don't know yet the mechanism. There are a lot of studies to try to understand what are the causes for that and how you could have interventions. Mask off. What do I think about the mask off, Natalie? I think it depends of the prevalence of the disease. If you have a lot of transmission in the population, I will recommend you wear your mask. But if you are in places like New Zealand, where you barely have no cases, having a mask or not will not change. I mean, it's more an handicap than something. If you are in India now and you say you want to remove your mask, I say you do Russian roulette. What is the most efficient measure to prevent cases like in Singapore? More than what we have now, I don't think we could do more than what we are doing now in Singapore. I think it's testing and maybe not going too strong on being a complete lockdown. I think it's the best is really go and go test, identify the cases, isolate the cases, and look for the dissemination and control the dissemination. If you do a more specific target, but you will never control completely. If you control, you do the New Zealand way, you close the country, you don't let people in. But if you want to have a country where you have people coming in and out, you have to be ready to have a certain level of cases which will come back. Okay, Sarah, if one shot of vaccine is sufficient for people already infected, is it recognized for France or in Singapore? This is still experimental, so the data are coming, and you know that there is always a lag time between the moment you generate the data and that the MOH analyze the data and take a policy. So, and sometimes this determine who is going to implement it. So in France, they say, okay, go for an injection. Singapore, they are in the mix for the moment, but I think they will decide soon if, and they will recommend to take one injection. It's not formally approved yet. Why not taking into account only cases that are symptomatic? Because the asymptomatic could transmit. Maybe I went too fast in the introduction, but if we were like in the SARS-CoV-2, in SARS-1 at the first in 2003, in SARS, people were symptomatic at the same time they were transmitting. Here you have a week where people, before they even sometimes become symptomatic, they could transmit. So you need to identify these asymptomatic cases and isolate them too. The vaccine deployment is not that slow in Singapore. It's a decision because it was targeting the people who were the most important to target, which means the older population and the healthcare workers, those who were in contact. And I can tell you that Singapore was in the top to order last year in June, the first dose was vaccine. Because you have to realize that last year in June, we didn't know which vaccine will be efficient or not. We had no data. So we did a review of all the vaccine, all the company to present the data and select. And then there were a pre-order of the vaccines. And then after the deployment, it's not bad for the moment, it's nearly 40%. But you have to also count into that there are the foreign workers, and the foreign workers in Singapore comprise, the non-Singaporean, it's nearly 2 million of people. The Singaporeans is 3.5. We had no data to vaccinate people at below 18 before. So you had to be very cautious how you deploy the vaccine. You cannot go full berserk like the Israeli of the US. And if you look at the data from the US, they are now catching up, but at the beginning, it was not as fast as the other country. The only country we went fast is Israel. And you know, they even start now to immunize, to vaccinate kids without, for me, enough data to really go into kids.
Thank you, Laurent. Thank you. I think it was a very interesting subject today, and you have a lot of questions, a lot of participants, a lot of questions. So thanks again for your presentation. Yeah. So yes, I can see a lot of thank you as well. So thank you. So this presentation is AfterLab. So you will receive a few invitations for the next AfterLab, and we hope to see you soon. We have one question from Christian. You raise your hand. Is the last question? Yeah. Let me ask. Christian? I think a lot.
No, I'm just clapping my hands.
You're clapping your hand. Okay, that's very good. Yeah, everybody's clapping. Now, thank you very much. It was very interesting and a lot, question. So thanks, Laurent. Thank you, Noémie.
They want to reinvite me. Okay, I will do later this year.
Exactly, later in the year when we know when we'll have more information as well.
Yes.
Thank you, everyone, for your participation today, and I wish you a very good evening. Thank you.
Thank you.
Bye.
Merci,
Thank you,
Laurent.
bye. Thank you. Bye.
Thank you. Bye.